So that being said, okay. So this slide should look familiar to you, okay? Because in lab class we talked about it. So I'm just going to kind of fly through it. And in case you don't know me very well, this stuff here is really important. If you understand histology, then you'll understand the physiology of the overall function of the heart. It'll just make sense. I'm going to explain it to you because I tell folks all the time, I'm the smartest dumb guy I know, okay? So I try to put it in a really simple and easy way that you'll understand, okay? So we've talked about some of the characteristics of some of the cardiac muscle tissue, okay? And we all know where cardiac muscle tissue is located. It's going to be in the middle layer of the heart in the myocardium, all right? And our cardiac cells are that Y-shaped or branch cell that has striations. And since it has striations, that means that it has myofilaments, the actin and myosin. So we know how that operates from chapter 10 and 210 in Bio 210 because we learned about how the cross-bridge cycling works. Same type of mechanism, so we don't have to review that. But just a couple of characteristics that we've seen, all right, is skeletal muscle is striated also. Our cardiac muscle, all right, is striated. Skeletal muscle is multinucleated. Cardiac muscle has 1 to 2 nuclei, okay? So again, some of the parts of the muscle cell we give special names to. We call the plasma membrane the sarcolemma, okay? And very similar as to skeletal muscle, we saw those invaginations, which we call those T-tubules. That's where the action potential will kind of go down in there and trigger the opening of those voltage-sensitive calcium ion channels to release calcium from the sarcoplasmic reticulum. All right, we'll see the same thing here. Okay, so those T-tubules will be found here, all right, in the sarcolemma. Okay, and we talked about endoplasmic reticulum, smooth and rough, all right, and just normal cell cytology. Well, here, all right, our sarcoplasmic reticulum, we call that our endoplasmic reticulum, we call that a sarcoplasmic reticulum. And just think of it as a tubular network, all right, like the sleeve on my arm here, okay? My arm is the myofibril, okay, where the sarcomeres are, and then the sleeve is going to be the sarcoplasmic reticulum. It's going to cover, all right? So the sarcoplasmic reticulum is going to hold on to that very sought-after calcium ion, okay? Because we need that. We need that calcium ion to do what? What does calcium do in the whole cross-bridge formation? What's its role? You remember? It's going to remove the troponin, tropomyosin regulatory proteins. All right. So remember how that those regulatory proteins are blocking the actin binding site. Okay. Well, they sit on there when it's at rest. Well, when the calcium comes in, it removes that whole complex so they can start to have that cross-bridge formation. So that's why we need that, okay? So the myofilaments, all right, are going to be the actin myosin, and one functional unit is known as a sarcomere. So what happens is when we start stacking sarcomeres from end to end to end, then we get a myofibril, okay? And that myofibril will then be surrounded by the sarcoplasmic reticulum here, okay? But this, I drew this to your attention in lab. This is very important, okay? When we talk about the contraction of the heart, okay, and we learned this a little bit when we were talking about skeletal muscle in chapter 10, but we learned that the more, I shouldn't say the more, there's a certain amount of overlap that we want to have between the actin and myosin filaments. All right, so when we get what we call that optimal overlap, if you look at my fingers here, all right, there's no overlap here, so you're not going to get a very good muscle contraction. All right, this is too much overlap because we can't get any further movement because my fingers will run into each other. All right, so it's going to be somewhere in the middle, and I'll show you here. Where are you? Oh, I guess I don't have it on this slide. All right, well, I'm not going to keep looking. All right. But you'll have, and it's, I could go back and pull up the chapter 10 one, but I won't. Yeah, I don't have the cross bridges there. Anyways, you will, we're looking for that optimal overlap. So it's like the Goldilocks effect. Too much overlap, not good, because we can't contract any further. Too little, if none, all right, there's no cross-bridge cycling going on. You want it to be somewhere in between, and there's going to be an area in between where we get that maximum amount of overlap that's going to be optimal for contractions. All right, so that's what we look at. What situation provides that optimal overlap? When there is blood in the chamber of the heart, because it stretches, all right, the heart wall. All right, and when you start to get that stretching of the heart wall, all right, you're going to start to maximize that overlap. And then just in time when a contraction or depolarization of the cell occurs, then we get that contraction, we'll be able to force that blood out. Okay? So when we get more overlap from the filaments, we can get more force for contraction of the blood. Okay? All right. This part right here, talked quickly, the desmosomes and the gap junctions, which are located in the intercalated discs. The desmosomes are the physical connections between the cells that allow for stability of the myocardium, right, when we are contracting, okay? And then our gap junction are those holes that we find in between the cells, and that's going to allow that facilitation of communication between the cells for ion flow, okay? Because we're going to review, all right, remember, ions are going to be flowing through these cells, all right, to create that electrical chemical gradient so we can get a depolarization. And what follows depolarization of a muscle cell? What do muscles do? Contract. That's right. Yep. So when we depolarize the cell, we're going to contract the cell soon afterwards. So these gap junctions allow for ions to flow across so we can better depolarize the cell. Okay? So that's what we're talking about with that facilitating communication here. All right? But that leads me to the next point. I talked about this on Monday, this functional syncytium. And I was thinking, you know, what's a good way to describe how to help you understand what a functional syncytium is? We have two rooms, the one that we're presently in and the one next door that my colleague is teaching in. Okay? So I had 20 people in here, and I have 20 people in the other room. And I want to choreograph a dance. All right? And I want everybody in both rooms to be able to move, all right, optimally and in unison and whatnot, all right? That's kind of like how it is. That's difficult. It's not easy. But if I only had like one or two people, that's a lot easier, okay? So trying to get, all right, the atria to contract at the exact same time and all those cardiac muscle cells to contract at the same time is very difficult. So in order to facilitate that and improve that, we improve the communication, all right, between the cells. How do we do that? We just poke holes, all right, in between the cells so the ions can flow through that much easier, that much more effectively, so we can get better depolarization, so we can get in unison contraction. And we'll see that in that video if I can get the volume working on the overhead speaker there, okay? All right, we've seen this picture. We've already seen that picture. All right, metabolism, okay? Our metabolism for these cells, all right, obviously our heart is working 24/7. It doesn't stop, all right, unless you're dead or unless you make it stop for whatever reason, all right? So it burns through a lot of energy, okay? And so we need to make sure that we have a high amount of mitochondria to help make that energy, and what helps with creating energy, nutrients, okay? What brings the nutrients in? Our blood supply. So our heart needs to have a decent blood supply. And then we got our players here, myoglobin and creatine kinase, which will help with generating energy, all right, and creating that ATP. And you look down here, and I talked about these fuels here, okay, the different fuels that the heart likes to use. Has anyone here ever gone to a buffet? Shoney's used to have a really good breakfast buffet. I don't know if there's any around here. When you go to a buffet, though, well, I know. I mean, when I was in college, I loved it because it had all-you-can-eat bacon, all right? But my point being is, when you go to a buffet, there's certain things on that buffet that you like. You're like, oh, I'm getting some of that. I'm going to get some of that. And there's things like, that's okay. And there's something like, I'm not touching that, all right? That's what these fuels are like here, all right? The heart loves fatty acids. Get a lot of energy from that. Loves glucose. Now it's kind of like lukewarm on lactic acid. Yeah, you know, lactic acid's okay, amino acids. Ketone bodies are like that pudding. I've never eaten pudding at a buffet, and I never will eat it, all right? It's just, who knows how long it's been sitting there? Like Jell-O too, all right? Certain things, though. Anyway, and if you like pudding, that's cool, but I just won't eat it, all right? But so the point is, these fuels are listed in their order of preference, okay? So the heart would really love to focus on just these two. It'll go through the other ones if need be, okay? But if energy levels are good, blood supply is great, mitochondria is wonderful, then you're good to go, okay? Predominantly, the heart wants to undergo aerobic cellular respiration. The mitochondria make that possible as long as oxygen is present. If oxygen isn't present, then you can enter into anaerobic cellular respiration, and for the workload that the heart has to go through, you're going to burn through all that fuel quick. You're not going to create enough ATP, and you're going to run into this situation here, ischemia, okay? And then the end result could be a myocardial infarction. You'll get tissue necrosis of the heart, of the cardiac muscle tissue, usually in the myocardium. Most commonly, it's in the left ventricle or the interventricular septum there. All right, those are the most common places for that to occur. All right, that's why it's important that you have an extensive energy supply, but really it's important that you have a decent amount of blood flow. All right, you occlude the blood flow. All right, now you're cutting off nutrients. Okay, you start to cut off nutrients to the heart, then we're dealing with an issue here, and it could result in death. Okay? Okay. Good so far. All right, let's get into the new stuff. I just wanted to review that because you want to have a pretty decent understanding of the histology, right, and the cytology of the heart, because we're going to deal with some of that. So our heart is made up of, all right, a couple different what's the word I want to use? Items, okay? The first is the conduction system. For those of you that have ever undergone or had to do an EKG, all right, or an ECG, that is an electrocardiogram. That's when we're actually checking out the electrical wiring of the heart. And that's what we're going to deal here with. We're going to start off because we need to understand what's going to stimulate the heart. You already know that the heart is made up of, or at least what we're interested in, is the myocardium, the contractile unit of the heart, all right? So we have a general idea of how that works, all right? We're going to get into more detail, but let's first talk about what triggers that to contract, and that's going to be our electrical system or the conduction system here, okay? So important things as you're reading through your notes and you see here in the slide, first thing I put up here is it initiates, okay? So the conductive system of the heart is going to initiate, all right, the contraction, all right, and we'll get into that, okay? So we have specialized muscle cells, all right, inside the heart. You have the cardiac muscle cell, but you also have the nodal cell, all right, which is part of the electrical conduction system. These cells are going to initiate the action potential, because remember, we need an action potential first, all right, then we'll get depolarization, then we'll get contraction, okay, followed by relaxation, then it recycles itself. Okay, so for all this to occur, timing is of the essence. Certain things can mess up the timing. When that happens, then you can get an irregular heartbeat. If you get an irregular heartbeat, you can get irregular blood flow. When you get irregular blood flow, you can get clotting. And when you get clotting, you can get death. Okay, there's a whole series of events that can occur from that. Okay, so we're going to talk about these cardiac muscle cells that are going to involve our action potentials, but they do not contract, okay? Those are the nodal cells. We'll talk about them. Their job is just to make the, I hate to say it, I don't want to say electricity, but they're going to be like the wiring system for the heart, okay? Huge. Autonomic nervous system controls heart activity, okay? Going back to our nervous system. If we break down our nervous system, there's two parts when we're talking about the functional nervous system, right? You have the somatic nervous system. You remember what that is? Voluntary, conscious perception, all right? The sensory aspect of the somatic nervous system, all right, is going to be our five senses, for example, all right? Sight, seeing, touch, okay, taste, all that. That's somatic, all right? And then the motor aspect is going to be voluntary muscle control over our skeletal muscles, okay? The other nervous system functionally is going to be our autonomic nervous system. Okay, the autonomic nervous system is the autopilot, stuff that is below, that operates below our consciousness, but is involuntary. And we're talking about the motor aspect. Okay, and there's two parts. Remember the two divisions of the autonomic nervous system? Yep, sympathetic, parasympathetic. Perfect, perfect, awesome, awesome. Okay, so what's the nickname for the sympathetic? Fight or flight. And what's the one for the parasympathetic? Rest and digest. Perfect. All right, good, good, good. All right. Okay, so let's talk about the players here in our conduction system. Okay, the first one, we probably all have heard this before because you've heard about pacemakers that we put into people's hearts. All right. Well, this structure here, the sinoatrial or the SA node, all right, this initiates our heartbeat. This is where it starts. So we nickname it the pacemaker. You need to know where it is. It's in the right atrium on the back wall there, on the posterior, kind of superior region of the right atrium. Okay? So what's going to start this ball rolling? Right? Initiates the heartbeat, okay? And then that that depolarization, that signal will wash over, all right, the walls of the atrium and cause it to depolarize and then eventually contract. Okay? So the next player is the AV, or the atrioventricular node. All right, it's located in the same atrium, except it's on the floor. Okay, right near the right atrioventricular valve, or the tricuspid valve. Okay, so far both the nodes are in the right atrium. Easy to remember. Okay, so from here, all right, from our AV node, we have this little collection of nerves here, and we call that, all right, our atrioventricular bundle, or also known as the bundle of His. I'm going to come right back to this slide here. Okay, so here's the sinoatrial node, or the SA node. All right, that's on the posterior wall of the right atrium. Then on the bottom, or the floor, there's our AV node. All right, and then we have our atrioventricular bundle, or the bundle of His. Okay. Then it branches off into right and left bundles, or bundle branches. And then eventually down here we get into our Purkinje fibers. Okay? All right, so the bundle of His, or the atrioventricular bundle, is going to be found in the interventricular septum there, in between the left and right ventricles. All right? And then about a quarter of the way down, halfway down, it splits off into right and left bundles. Okay? So if you've ever heard of a bundle branch block, right, that can occur when one of those branches has been destroyed or is malfunctioning, or something's going on there. Okay? And one of the ways to help diagnose that is through the ECG. Okay? And then eventually when we get down to the apex of the heart, then we have our Purkinje fibers. And those pretty much go up the ventricular walls there. Okay? So if we look here, you can kind of see that. All right, here are our right and left bundle branches. We get down to the apex, and then you can see how these Purkinje fibers just kind of fan out through the ventricular walls here. All right, kind of pop up into the papillary muscle here a little bit, all over the place. Okay? So when you actually look, and when we watch the video here, we'll see, all right, that in the ventricles, and it makes sense, the ventricles, when they start to contract, they contract from the apex and kind of contract upwards. That helps to push the blood upwards and out of the ventricles into the aorta and the pulmonary trunk. You'll see it and you'll understand it a little better. So these will start to depolarize first, and then they will help to cause these muscles to contract and push the blood up. Whereas with the atria, they'll depolarize from the top down, which makes sense, right? Because they're going to push the blood down into the ventricles, whereas the ventricles have to push the blood up and out. Okay? It's really kind of cool. Okay. Questions so far? All right. Am I going too fast, too slow? I'll slow it down. Ask me a question. No? I know. And I only slept for 3 hours last night, which is horrible.
You probably sleep 3 hours every night.
I wish. Because there's so much I want to do. No. I started, well, I think I've told you guys that I'm watching True Blood, and there's actually something that I can apply to this, but we'll get to that later on. My brain always thinks of crazy things, and that was one of the things when I was watching the show. Okay, so let's start where everything begins, in the brain. Okay, so we want to talk about, all right, we know now the electrical system of our heart. Okay, kind of how it works. We'll do a little bit better here in a little bit. All right, but let's start up and talk about how the brain influences this, because the heart can actually beat on its own. All right, literally, and this is my point. This is where the True Blood comes into play. A lot in this show, the vampires like to rip people's hearts out. But I noticed when I was watching the show, if they rip the heart out, it would still be beating. Okay, because it does. It'll beat on its own. All right, only obviously for a short period of time until the cardiac muscle cells use up all of the ATP in the cell, which won't take long. All right, but they never do. All right, but we have to control that heartbeat. Okay, because the heart wants to beat at a certain rate. All right, but the rest of our system, our body, does not want it to beat at that rate. It wants it to beat a little bit slower, and we're going to get into that here. So let's start off with the cardiac center. All right, we learned last semester where it's located in the brainstem, specifically in the medulla oblongata. All right, and so we have two components to the cardiac center. We have what's called the cardiac acceleratory center and the cardiac inhibitory center. So you can tell from the title there what the role is of both those centers there. All right, the acceleratory, what do you think it does? Yeah, it's like your gas pedal. All right, speeds up the heart. All right, inhibitory is like the brake, slows it down. Okay, real simple. Okay, so it's binary. It's one or the other, 1 or 0, yes or no. Okay, so how do we know which center we want to stimulate? No problem. Going back to what we know about homeostasis, remember our control center, the receptor control center effector, right? This runs in a loop very similar to that. You're going to have a stimulus, then you're going to have a receptor that's going to pick up that stimulus. So the two receptors that we rely on in our cardiovascular system are going to be the baroreceptors and the chemoreceptors. Do y'all remember what baroreceptors do? What do they monitor? Pressure. Yeah. Pressure on the vessel walls. Okay? Increased blood pressure or decreased blood pressure. Right? And they're located in a couple spots that we're going to talk about in a moment. All right, the carotid sinus, which is in your carotid arteries there, and then you have some baroreceptors in the arch of the aorta. Okay, this one here, what about the chemoreceptors? What do they monitor? Chemo meaning what? Chemicals. So let's be more specific. Blood oxygen levels, carbon dioxide levels. Okay, carbon dioxide levels are going to actually influence chemoreceptors, which blew my mind when I learned that in medical school. I always assumed it was the oxygen levels. No, carbon dioxide levels will play a larger role, believe it or not. All right, but we'll get into that later on. Okay, so baroreceptors and chemoreceptors. Now we have our receptors. Okay, so they're going to send information up to our control center, which is cardiac center. Okay, and whatever's going on is going to stimulate, all right, either one of these and inhibit the other. Okay, so now we're dealing with the autonomic nervous system. So we're dealing with both the sympathetic and the parasympathetic pathways. Okay, so from what we know, fight or flight, sympathetic, which center do you think the sympathetic is going to stimulate? Which one, here or here? Yeah, acceleratory one, okay? All right, and then it will inhibit the cardioinhibitory center, okay? All right, so important point, star this, circle it, make sure you know this, all right? The cardiac center does not initiate any type of activity. It only is going to modify it. It's either going to speed it up or slow it down, or the sympathetic does more than just speed it up. It can make the contractions more powerful, more forceful, okay? So it will increase the rate, or excuse me, not increase. It will influence the rate and the force of the heart contractions. It's the sympathetic that does both of those. The parasympathetic will only slow the heart rate down. Okay, we good so far? It's a really important slide. I really want you to have these basics. Okay, I know I draw a lot on these things. There we go. That could be distracting. Okay, Now, this next slide, and a lot of the writing in it is red, okay? So that means a lot of it is important, okay? So let's talk about both branches, or excuse me, both divisions of our autonomic nervous system, okay? We start off with the easier one. Parasympathetic innervation is going to decrease the heart rate. That's it, right? Does not influence the force of contraction. It just influences the rate at which the heart is going to beat, okay? So it's going to be, all right, responsible for influencing the cardioinhibitory center, all right? And if you remember, there's 4 cranial nerves involved in the parasympathetic nervous system. Cranial nerve 3, which is ocular motor, cranial nerve 7, all right, which is facial, cranial nerve 9, which is glossopharyngeal, and then one of my favorites, cranial nerve 10, vagus. Vagus does a lot, all right? For some of you who haven't had me before, if you're ever taking a test and it talks to you about cranial nerves, okay, as the answer choices, and it says a bunch of stuff in the question, you're like, I have no idea. Always answer vagus nerve, okay, if you have no idea, okay? Your best bet, because vagus does a lot, okay? So when we talk about the vagus nerve, cranial nerve 10, all right, we want to know which of the conduction system nodes, all right, that they control or influence, okay? I always remember LAV, L-A-V. The left vagus is going to influence, all right, the atrioventricular node, all right? And then the right vagus is going to do the sinoatrial and the SA node. That's how I remembered it, LAV. To each their own, okay? Okay, but parasympathetic, easy, easy. Sympathetic, all right, is going to, remember, fight or flight. It's going to speed us up a little bit. So it's going to increase our heart rate and the force of contraction, okay? So it's going to be responsible for influencing the cardio-acceleratory center there. All right, specifically T1 through T5. You need to know that. T1 through T5, all right, neurons that come off of the spinal nerves, all right, T1, T2, T3, T4, and T5, okay? And so these neurons are going to influence the SA node, the AV node, your cardiac muscle, the myocardium, right, and also coronary arteries. So you're probably thinking, what the heck, why coronary arteries? Okay, and we will talk about this. If you remember, there was a term, okay, that we talked about how arteries will vasodilate and vasoconstrict, all right? There's only one division of the autonomic nervous system that influences that, and that's the sympathetic division. The parasympathetic division has nothing to do with the blood vessel diameter. So if that's what you were thinking before, erase that from your brain, because it does not. The sympathetic is the only one that will influence the diameter of blood vessels, okay? Promise me that you know that now. All right? So keep that in mind. So in this situation, and we'll get into this in a moment when we talk about vascular tone or blood vessel tone. Okay? We'll talk about that. I'll review that concept here in a few slides here. All right? But that will then stimulate the coronary blood vessels to dilate, so we can get more blood to the area, so we can supply, all right, the tissues with more nutrients, remove more waste and whatnot, okay? All right, so this picture here, I'll zoom in a little bit, kind of shows you that relationship that we see here. All right, you got your parasympathetic and your sympathetic divisions, all right, all here, all right, in our medullary, the medulla oblongata in the brainstem here. All right, I'm not going to walk through all of this with you, but a couple things that you should understand, all right? You have some receptors that are going to be monitoring, okay, the content of our blood, of respiratory gases, our chemoreceptors, and then how high or how low our blood pressure is, all right? And that's going to be the baroreceptors. All right, the baroreceptors and chemoreceptors are going to be located up here near the carotid arteries, and then down here in the arch of the aorta, which makes sense, because you want to have I call it the early detection system right off the bat, blood coming right out of the aorta. All right, we want to make sure that it's not too high. If it's too high, we can cause damage to the aorta. The aorta is pretty much the hardest, toughest artery in the body. So if it's too much for the aorta, what do you think it's going to do to the rest of the arteries and blood vessels it's coursing through? Okay, so we want to monitor that, right? So we have our vagus nerves coming down, all right, from the brainstem here, also going to be influencing our SA and AV nodes here. And then we can see here, all right, we have some branches here from T1 through T5 coming from the spinal cord and our spinal nerves that are going to be influencing, all right, the SA node, the AV node, the myocardium throughout the heart, and the coronary blood system there, okay? So again, this is just kind of putting into a picture what I had here, okay? Kind of giving you a little bit of a heads up here. All right. Questions? So that's like the electrical wiring of the heart, right? So now we kind of know, all right, the wiring in the heart, and now we understand the wiring that leads from our central nervous system, our overall control center, to the actual end organ of the heart. So now we're going to talk about, okay, the contraction of the heart. Okay, so there's two components of that. Let's talk about the first one, the conduction system. Okay, the conduction system has nothing to do with actually contracting. Okay, action potentials don't do anything except tell another cell to contract. Okay, so these cells are going to send the signals, all right, for whatever the effect is going to be. Okay, our end organ, all right, is the cardiac muscle cells. So the conduction system, all right, is going to transmit that information from our central nervous system, and then it's going to cause, it will initiate, all right, the action potential, and then it's going to send that action potential to the effector tissue, which in this case are our cardiac muscle cells. And we saw, remember how the action potential and the skeletal muscle would wash across the sarcolemma and then find the T-tubules and go down into the T-tubules and then open up the voltage-gated calcium channels of the sarcoplasmic reticulum, releasing calcium, causing the cross-bridging, causing the contraction, all right? All right. That process of the action potential causes depolarization. What follows depolarization? Muscle contraction. So that's what we're seeing here. Okay, they're going to fire the action potentials, which will, it's not listed here, which will cause depolarization, and then it'll cause muscle contraction. Okay, it starts in the atria and then finishes up in the ventricles. Top-down phenomenon. Start in the atria, go from the top, work our way down to the ventricles on the bottom. Okay, atria contract first, ventricles contract second. Okay. So the two cell types that we're going to be dealing with here are going to be the cardiac muscle cells, which we're going to talk about in a second. But let's talk about the nodal cells. Okay, these are the cells that are fascinating. These cells are what makes it possible for the heart to contract on its own outside the body. Okay, they stimulate the cardiac cells to contract. Okay. So these cells here, all right, we're going to find, all right, in our SA node. Okay. So they will again initiate that action potential. And that action potential, it's like me taking a bucket of water and splashing it onto the wall. All right. The water will run down the wall. That's what the action potential will do on the atria. It'll just spread out. All right. It'll go down the walls of the atria and it'll spread outwards. Or it's like taking a rock and throwing it into a lake. It spreads out. Okay. That's what happens here. All right. With nodal cells in the SA node. They just send the action potentials just out in every direction, 360 degrees in every direction, and it'll cause depolarization of the atria here. So that's what this picture here is kind of showing us. All right, the SA node, all right, is going to initiate those action potentials, and they go all the way, they go out in all directions and downwards here towards the atrioventricular node, all right, or the AV node. Okay, we'll talk about that whole process. All right, this is what I wanted to show you. I just didn't go far enough here when I was looking for this picture here of the overlapping of the sarcomere here. Okay, the other cell that's going to be involved in this phenomena is going to be our cardiac muscle cell. Okay, so it's going to receive the action potential. All right, it'll also what we call propagate the action potential or foster it to move across the sarcolemmas. So it'll spread out like throwing a rock into the pond, going down into the T tubules and releasing calcium. All right, from those sarcoplasmic reticulum that are there. But also we have those gap junctions that will allow ions to flow through so we can depolarize neighboring cells. All right, so it happens very fast. Okay, so we're going to see here eventually after the action potential will cause depolarization. All right, and then we'll get our cross bridge formation and our muscle contraction. Okay, we learned all this in chapter 10. Okay, so let's start off at the beginning. The lub-dub. Has anyone ever heard the last section here that we're in class? When I asked about lub-dub, no one was familiar with that. All right. So lub-dub is the heartbeat. You know, the S1, S2 sound. All right. To me, I don't know where the lub-dub came from. It never sounded like lub-dub to me, but it's like boom, 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 boom. Okay. So that is going to be a heart cycle. Okay. So let's start off at rest. So we just finished the contraction and we're starting to relax. Now here's what's going to happen. First of all, you need to circle this. These cells, all right, the nodal cells, first of all, are located in the SA node. All right, again, they're responsible for the initiation, all right, of the muscle contraction. They initiate the action potential, which is followed by depolarization, which is followed by contraction. Okay, so they initiate this, but they have this phenomenon that we describe as spontaneously depolarizing. Okay, they don't need to be told to depolarize. Nothing needs to happen. They'll do it on their own. Okay, they just do it. It's like that kid with Tourette's that just keeps randomly yelling stuff out. I'm not making light of Tourette's, but you know, just saying it just doesn't need to be told what to do. It'll just do it. Okay, so you all remember this term, resting membrane potential, right? You need to know this value for the nodal cells. Our resting membrane potential is -60. For cardiac muscle tissue, it's -90. Okay? So here's what happens, all right? The resting membrane potential is -60, okay? And it's described here as not being stable, all right? Which means it's just not going to stay there very long. It gets to once we get to -60, all right, then we're going to start to depolarize the cell. I'll get into that in a second. All right, so a little review, okay? These cells are similar to some of the other nervous cells, all right, that we've talked about, like a neuron, okay? They have the same membrane proteins. Remember this guy? Sodium-potassium ion pump, 3 sodium out, all right, 2 potassium in for 1 ATP, okay? So we have that. Calcium ion pumps, we saw that before. Remember the synaptic end knobs have those, all right, to pump calcium out to create that concentration gradient. That's what these guys, in fact, all of these, even the leak channels, these 3 membrane proteins are all responsible for what we call the electrochemical gradient, all right? And that's this, our resting membrane potential. Those structures are responsible for that -60 millivolt resting membrane potential, okay? So we have a couple new things that we haven't been exposed to. All right, we've been exposed to voltage-gated sodium channels, but not slow voltage-gated. All right, we've never talked about that before. And then we have fast voltage-gated calcium channels. We've already seen these guys before, voltage-gated potassium channels. Okay, so there's a reason why we call these voltage-gated sodium channels and these voltage-gated calcium channels slow and fast. All right, I'm going to go over that with you. Okay, so these two are the new types of proteins that we're going to talk about. Okay, so slow sodium, fast calcium. Okay, so you can see a picture here of our nodal cell. Okay, centralized nucleus here. All throughout the plasma membrane, we have these channels located throughout. Okay, so what's the purpose? Let's talk about how, all right, a nodal cell will start to initiate, all right, an action potential. Okay, So, huge. This phenomena, all right, autorhythmicity, okay, which is just that spontaneous firing, okay? And after I describe and explain this to you, you'll understand why we label, all right, these nodal cells, all right, with this term of autorhythmicity, okay, that spontaneous firing. So we start off here, all right, we have our threshold, okay, of -60. So what will happen is, once we're at this -60 millivolt value, as soon as that happens, these slow voltage-gated sodium channels will just open up. Okay, they open up, and sodium flows into the cell. What is it called when we make the inside of the cell more positive or less negative? What do we call that phenomenon? I've said it like 6 times today. Depolarization. Okay? So these positively charged ions are going to flow into the cell, okay? And that is going to push, all right, our membrane value, our membrane potential to -40, okay? As soon as that happens, that's our new threshold value, by the way. What was the threshold value in neuron? Remember, what's the resting membrane potential in neuron? -70. So do you remember what the threshold value was in a neuron? -55. Good. All right. All right. So in this one, our threshold value is -40. As soon as that happens, our fast, all right, voltage-gated calcium channels spring open. Okay, and calcium pours into these cells. It doesn't just flow in; it pours in. Okay, and that's going to bring our our membrane potential to not -0. There's no such thing, to 0. Okay, so that's going to then cause, that's that depolarization. Now we've just caused that cell to depolarize. Okay, so what always follows depolarization? Repolarization. Okay, so as soon as we reach this negative, I keep saying that, this 0 millivolt value, then our potassium channels are going to open up. All right, our sodium and calcium channels have closed already. Okay, so at 0, all right, calcium channels close, and then our voltage-gated potassium channels open up, and of course, potassium is going to move across, all right, its concentration gradient from inside the cell to outside the cell. So that positive ion leaves the inside of the cell, making the inside of the cell more negative, and so we're repolarizing the cell. And as soon as we get back to our resting value of -60, all right, our slow voltage-gated channels open up again. And it just keeps repeating. That's what happens. So this whole phenomena, all right, is why we refer to it as having a spontaneous firing, all right? Because it's like one event triggers another event, which triggers the next event, and then that last event triggers the start of the first event again. And it just keeps going. It's a cyclical thing, okay? So it's not getting any type of stimulus from outside of that, other than the fact, all right, that it reaches a certain threshold value, not threshold value, membrane value, and then it triggers the next event from going on, okay? So that's why these cells will keep depolarizing, all right, on their own. All right, as long as there's ions present and as long as there's ATP, all right, because again, we need ATP to operate the calcium ion pumps, the sodium potassium ion pumps, all right? That's why we need ATP, and that's why the heart can't beat on its own outside the body for a long period of time. All right, questions about that? Okay, so when you and I are sitting here, I'd like to think that we're all at rest. Okay, so when this occurs, all right, this phenomenon, well, I just talked about those 3 things, all right, depolarization, all right, repolarization, and then, you know, repeating all that threshold value at rest. That takes, all right, almost a second, okay, 0.8 seconds. All right, so in a minute, all right, the heart wants to beat at about 70 beats per minute, 75 beats per minute. Okay, but The SA node goes faster than that. It goes at about 100 beats per minute. Okay? That's the high end of the normal range for heartbeat, right? 60 to 100 is the range, right, for heart rate. Average is 75 to 80. All right, if you're low, Miguel Indurain, who was a big cyclist, I'm aging myself, this is almost 30 years ago. He had a resting heart rate, this guy was big, of 24. Can you imagine? I mean, that'd be kind of nice. No, I take it back, 27. But still, that was his resting heart rate. That's how effective his heart was and how well trained his body was. I'm happy to have like 42 or 45 or something like that, or even 50 when I was in really good shape, right? But here's the thing. We're not that high unless something's going on, okay? So what happens? This guy kicks in. The parasympathetic nervous system kicks in, all right? We refer to this as vagal tone, right? And it slows the heart rate down, okay? It slows it down. So your heart is under parasympathetic, all right, activity. It's under its influence, okay? So that cardioinhibitory center is being stimulated, right, as you're sitting here. Because otherwise, your heart would be beating 100 beats per minute, okay? So, all right, when we talk about that autorhythmicity, okay, we refer to this right here, the pacemaker potential, okay? And that pacemaker potential, all right, allows us to reach that threshold value, all right, of that -40 without any type of stimulation, all right? That -60, to open up those those slow voltage-gated sodium channels, we don't need a specific outside stimulus or any kind of stimulus, all right? Once we hit that value, they open up. And then once you get to that threshold value of -40, the fast voltage-gated calcium channels open up, all right? So there's no stimulus that occurs, all right? You just have to reach a value for those things to happen. So that's what allows these cells to kind of beat on their own, or I should say beat on their own, but kind of depolarize. So this is what the electrical, if we were to put in an electrode into these cells like we did with the neuron, all right, and see how the actual cell depolarizes, this is what it looks like here. Here's our threshold value of -40. All right, here's our resting membrane potential of -60. And you can see this is time on our x-axis, all right, voltage, all right, our membrane potential is on the y-axis. You can see it takes a little bit of time here to go from our resting membrane potential, all right, to our threshold value. But as soon as that occurs, all right, it takes virtually no time whatsoever, all right, to get up to that, for depolarization to occur, to get up to that 0 value there, all right? So when our sodium, our slow voltage-gated sodium channels are opening up and sodium is moving in, that is our pacemaker potential, right? There's no stimulus that is causing that to occur, right? Simply, we were at -60 and that caused the channels to open up, right? And then you can see as repolarization, right, the only thing that's occurring is potassium is leaving the cell, okay? And then starting the whole process over again. All right, this slide here is just showing you, hold on. All right, this slide is basically showing you what I was just talking about, okay? So to reach our threshold, all right, we're at -60 resting membrane potential. All right, sodium enters into the cell, causing depolarization of the cell, okay? And as soon as we get to that -40 value, all right, our slow sodium voltage-gated channels have closed. Fast voltage-gated calcium channels open up. Calcium pours into the cell and immediately brings us to our 0 value for the membrane potential. And as soon as that happens, then our fast voltage-gated calcium channels close down, all right, and then our voltage-gated potassium channels open up for repolarization as potassium leaves the cell, and we make the inside of the cell more negative again. When we get to that -60 resting membrane potential, starts over again, whole thing, okay? All right. All right. So now we know how the nodal cells depolarize. Okay. So how does the rest of the the conduction system depolarize or get its action potential, and how do the atria, all right, depolarize? Well, that's a great question. Okay, because I'm going to tell you. Okay, so let's talk about what happens as the SA node depolarizes and it sends out its action potential message in 360 degrees all over the place. All right. As our action potential spreads, we're going to see it move across the atria. Eventually, it's going to reach the AB node here. Okay. This phenomenon happens so fast. All right. And it's in part, again, due to those intercalated disks. Those gap junctions allow the ions, all right, a way to flow across the sarcolemmas. So we can actually initiate action potentials and propagate action potentials across the cardiac muscle cells there. All right. So as it's doing that, right, eventually that action potential is going to hit the AV node here. Now the AV node, and I should have said this earlier when we were talking about it, it should be nicknamed the bottleneck. Okay? We need a brief moment to slow this process down, right? Because the atria have to contract and finish, because what happens when the atria contract? What are they doing? Do you remember from Monday? They're pushing blood into the ventricles. Remember in the beginning of the ventricles, we have passive filling, all right, where the AV valves open up and blood's pouring into both the atria, but then because the AV valve is open, it dumps right into the ventricles, and the ventricles start to fill up. Well, eventually the AV valves will close. And so the atria, all right, well, no, take that back. But eventually, before the AV valves close, the atria will contract to get that last little bit of blood into the ventricles, okay? When that happens, then the AV valves will snap close. But we want to, that's the active filling, okay? But we need a moment between when the atria contract before the ventricles can contract. And the AV node gives us that moment. It slows things down just for a split second. So the atria can contract, okay, and finish contracting before the ventricles contract, okay? So that's why, and I say we should call it the bottleneck here. I thought I had that written down here. Well, I didn't have it on here. Well, oh, there it is, bottleneck. Okay, so as we see here, we slow it down, right? And that's because, well, one, there's only one pathway. All right, it's the bottleneck because everything has to, for the rest of those action potentials or nerve signals to carry on to the ventricles, they got to go through the AV node. Okay, and part of the reason why things slow down is because there's fewer gap junctions, but here, smaller diameter. Remember, there's two things, all right, that affect the speed of an action potential. One is if a neuron is myelinated or non-myelinated. The other one is how big the neuron is. Okay, remember, diameter, it plays a big role, like a pipe. You get more water flowing through a bigger pipe than you can a smaller pipe. All right, a bigger nerve is going to conduct action potentials faster. Okay, smaller nerves don't. So that's what we're seeing here. We have a smaller diameter, fewer gap junctions, all right, and the fact that we've insulated the area so the action potential can't escape. It can only go in one direction into one place, and that's towards the AV node here. So that brief, all that allows us that brief moment, all right, that brief pause, so the ventricles can finish filling up before they can contract. Okay, so the action potential then travels from the AV node down, all right, our atrioventricular bundle there. Okay, it goes from the AV node to the AV bundle, which then branches into our right and left bundle branches. All right, this is all in the interventricular septum, and then out to the Purkinje fibers. The Purkinje. Yeah. Oh yeah. Yeah. Oh yeah. And then from there, okay, the action potential will spread across the ventricles as it did in the atrium, through the gap junctions and whatnot through all the cardiac muscle fibers. And that phenomena helps both of the ventricles contract at the same time. It's really quite amazing if you think about it. We take it for granted because we're all relatively healthy, I think. So these next two slides are just basically telling us, I'm going to go through it picture style. I like pictures. Okay? So here we can see, all right, in the first part of it, okay, this is where we get our SA node starts to depolarize, all right, and it starts to trigger the depolarization of all the cells around it, all right, and it depolarizes all the cells over here through the atria, and it washes down, okay, like if you were to splash paint on the wall, it moves down. So once depolarization occurs, what follows the depolarization is going to be the muscular contraction. Okay? So as it depolarizes, it washes down towards the atrioventricular node here. Okay? And that's where we get our slight delay. Our electrical current cannot go anywhere else. It can't go down the outside here in a normal heart. Okay, because there is a situation in which you get some special white. Has anyone ever heard of Wolff-Parkinson-White syndrome? It's when you have just an irregular wiring to your heart. I had a patient of mine, I got a few moments. I got a patient of mine that he's 22 maybe, 23, who was going to the gym, going to work out with some of his friends, and he says, oh, I forgot something at the car. Goes out to the car, doesn't come back in. His friends are waiting around inside. They're like, well, where the heck is so-and-so? So one of them goes out there to the parking lot. He's laying face down, not moving. So they run over there. He's not breathing, no pulse, nothing. They call 911. In the meantime, they're working on him, CPR and whatnot, okay? Somehow they get him, they revive him. He'd been out for like 15 minutes. No heartbeat, nothing. 15 minutes. At 6 minutes, you start to get brain damage. It's an amazing story. Anyways, they bring him back to the hospital. Long story. Get him back alive, obviously. And so they ran all tests. And the doctor came in and said, listen, you have this condition called Wolff-Parkinson-White syndrome. It's basically your conduction system of your heart. You have extra wires where they shouldn't be. And so your heart is depolarizing, and it just causes it to stop. And that's one of the rare possibilities. You don't know you have it until you die from it, all right? Or I mean, that's really, I mean, no one thinks to check it because it can be asymptomatic for a long period of time, all right? Anyways, doctor said, listen, if the moon, if the planets are in alignment and the stars are perfect, because I'm going to do a procedure on you, and it should fix it, if that's what caused you to have this problem. Well, they did. They went in there, they cut the bad wiring, so to speak, out, and he's fine. It was the craziest story ever. It was on the news. And so, yeah, he was dead or not alive. They estimate anywhere from 10 to 15 minutes. And if you talk to him, you would not know. Normal, well, as normal as you would think that I am, but I mean, it's as normal as anyone here. I mean, doesn't have any deficiencies or anything. It's really an amazing story. Okay, so we get to the AV node here. All right, our action potential gets to the AV node. We have that slight delay, and then the AV node depolarizes, and it starts to send, all right, the action potentials down the atrioventricular bundle, or the bundle of His. Okay, then it splits in the interventricular septum. We get our right and left bundle branches. And then down here in the apex, all right, this is where we get our Purkinje fibers. And the Purkinje fibers, well, I'm jumping ahead, sorry. There we go. Okay. So we get that depolarization. It travels down, all right, the atrioventricular bundle here. Then it splits off into the left and right bundle branches, and then it goes out to the Purkinje fibers, all right, here. And what the red here is displaying, all right, we start to depolarize the apex first, and then it starts to, the depolarization works its way up to the atria. So that's why the muscle tissue down here starts to contract first, and it forces the blood up. Cool, right? I think it is. Okay. Let's just finish up talking about the conduction system, okay? So when we talk about going back to, all right, the parts of the conduction system, when we talk about the Purkinje fibers, there it is again, larger in diameter. So what does that mean? That means the action potential speeds up in that area. So we have a quicker depolarization, which is good. You want it to be faster there than in the bundle branches, because that's where we want to have the apex start to depolarize first, right, and work its way up and contract up towards the atria. Okay, so all of this it causes obviously a rapid onset, all right, but it has to be quick enough, but not too quick, all right. So when we're repolarizing, we can actually get the ventricles, all right, to contract simultaneously. Not only that, but they have to contract after the atria have contracted. Okay, you can't have them working at the same time. It'll mess up the valves. Okay, so talking about a ventricular contraction, I cannot not talk about the papillary muscles. Remember the papillary muscles? These muscles that sit on the inside of the ventricles. They have the chorda tendineae that come off, which are these collagen-type fibers that attach onto the valves, okay, the leaflets of the valve. Has anyone here ever gone parachuting, skydiving? I don't even think parachuting is a term, but anyways, all right. Have you ever watched somebody parachute, and they float down, all right, and land on the ground, and the parachute's kind of still up in the air? What do? They pull down on it so it doesn't blow away or whatever. You never went parachuting? No, right? No. Well, anyways, so you're pulling down on it, and that's kind of what the papillary muscles and the chorda tendineae and the valves are like. As you're trying to pull the parachute down, that's what, when the ventricles are contracting, those papillary muscles are contracting, and they're pulling on the chorda tendineae to keep the AV valves closed. Because remember, as the ventricles contract and push everything up, they're going to push up against the AV valves. Those need to stay closed. All right, so the chorda tendineae pull down on them so they don't flip open into the atria. So the blood can only go through one set of valves, and that's going to be the semilunar valves, through the pulmonic trunk there and through the aorta. Okay, so that's their job. Okay, they're going to make sure that that blood only goes to what we call the arterial trunks. That's the aorta and the pulmonic trunk, pulmonary trunk, pulmonic. Has anyone ever heard of an ectopic pacemaker? No? Okay, we're going to talk about it. All right. It's just located, there's a couple different types of ectopic pacemakers. See, obviously, you know, we call the SA node the pacemaker because it's going to initiate the whole action potential startup, okay? But in a certain situation, if it gets damaged, or for whatever reason, you might have nodal cells located somewhere else. It might be in another area of the atrial wall, okay? And that messes things up. But so basically, when we talk about ectopic pacemaker, it means our pacemaker is somewhere other than the SA node. And that's a problem. Yeah. And so it could be anywhere. But we have, all right, those nodal cells, all right, that are still spontaneously depolarizing. Well, that could be bad. Because remember, it's all about timing. Okay, we have to get our timing down. The atria have to depolarize at a specific time. The ventricles have to depolarize at a specific time. So if we have an ectopic pacemaker somewhere, spontaneously depolarizing, and it's not in sync with our SA node, then that's going to be messing stuff up. Okay, so this is going to cause a situation where, all right, we're going to get irregular depolarization. All right, which will cause slower rates, all right, which will eventually get, well, depends on where the ectopic pacemaker is. If it is the AV node, all right, then we're going to drop our rate down to 40 to 50. Now, that's not bad if you're conditioned for it. All right, you can live like that. It's not ideal. I'd still feel safer putting a pacemaker in the patient than having to rely on the AV node, because if the AV node goes, then you're done. Because if we don't have AV node, our cardiac muscle will spontaneously depolarize on its own, but at 20 to 40 beats a minute. And it's not going to be enough for most people. It's just not going to be enough. Okay? Oh, do I? Yes. Morgan said yes. Oh, to skydiving. Oh, nice. You know, if you go skydiving, you can't have a life insurance policy.
What?
Did you know that? If you have a life insurance policy and you go to skydiving, that can null and void the life insurance policy. And, well, no. I mean, if they find out that you're doing that, they're like, you're taking reckless, most life insurance policies won't allow that. Well, now I found out for one of the ones that I was looking at for scuba diving. If you go scuba diving.
You're gonna be dead, so.
Well, I don't scuba dive.
I don't like to.
I'm afraid of jellyfish. Has anyone here ever been stung by a jellyfish? Yeah, it hurts. Plus, there's sharks in the
I've
ocean.
tried to.
I remember when I was like 7, it was like my first jellyfish sting. I had like 18 on my stomach.
Hurts.
From, like all the tentacles.
You gotta pee on it.
Well, some lady had like
It's true.
meat tenderizer,
Yeah.
Yep.
steak tenderizer, and she heard me screaming and crying. She came over to my mom and was like, "Put this on it." And
I can't remember why urine helps.
I don't know.
I think it's the nitrogen or the urea.
Whenever I was younger, we always used to beef all the time when we ever got stung. I've never been stung, but I know a lot of people who have. It like instantly.
Yeah. It was a Friends episode they were talking about it.
Yeah.
Is that what you were talking about? And I pee on all of you. Joey. That's funny. All right. Let me just jump. Wait, okay. Let me just jump in here and talk about cardiac muscle cells. We're doing really well on this, but I just want to kind of jump in here because this is somewhat review when I talk about the cardiac muscle cells. When we talk about some of the membrane proteins, same situation, all right, that we saw before in previous cells. We have our sodium-potassium ion pumps and our calcium ion pumps, but then we also have leak channels. So we saw that in the nodal cells, okay, and we've seen that in neurons, okay. So that's similar. We all know how that operates, okay. Here, all right, when we're dealing with the cardiac muscle cells, all we're going to do is flip-flop the adjective for the voltage sodium gates and the voltage calcium gates. So now in this situation, when we're dealing with cardiac muscle cells, now we have fast voltage gated sodium channels and we have slow voltage gated calcium channels. Potassium channels are the same, okay? The only thing that changes also is our resting membrane potential, -90, okay? All right. So, phenomena when these cells are at rest, different than nodal cells. They don't spontaneously depolarize, okay? So at rest, all of our voltage-gated channels are closed. It's going to be different, okay? So it's going to be almost like our skeletal muscle cells, okay? When it's at rest, gates are closed. Right? Nothing's going on, okay? All right. Almost there. Covered more than I thought I would. All right, so here's our cardiac muscle cell at rest, kind of doing its thing. All right, you can see all of our gates are closed here. As much as I want to start this, I'm not going to, okay? Because it'll take me longer than what I have time for. So, fingers crossed, people. I'm going